What do recent findings from switch studies suggest for the management of patients who have maintained virologic suppression and high CD4 cell counts with the long-term use of older agents?
When I talk about switching to clinicians, a lot of times I hear this expression come up over and over again, and that is, if it ain't broke, don't fix it. And the implication of that expression is that unless somebody is failing or experiencing toxicity, that you shouldn't switch, you should leave things alone. I don't really like that viewpoint. And if you look at the DHHS guidelines and their discussion of switching, they list a number of reasons to switch that go beyond that those very limited indications. So they include switching for greater convenience, for lifestyle improvement, quality of life improvement. And they also include the prevention of failure and the prevention of toxicity. So as an example, you'll see people who are still on AZT or even worse, D4T or DDI, who are not experiencing overt toxicity, but it's entirely reasonable and advisable to change those people because you're trying to prevent toxicity. So we know that those are mitochondrial toxins, that they're damaging mitochondrial DNA, and although they may not be experiencing toxicity now, you can't predict that they won't develop hepatic steatosis or lactic acidosis, lipoatrophy, neuropathy, pancreatitis if they continue to use the drugs. Similarly, there are patients still even on indinavir, which is a very toxic drug that we've abandoned use. And sure, you could say that this patient doesn't yet have kidney disease or kidney stones, but why would you wait for that to happen before making the switch? So I think, it used to be that in switch studies there was always that risk that you would jeopardize virologic control. Or that you might replace one toxicity with another. But I think if you look at more contemporary switch studies where we're switching from one first-line regimen to another first-line regimen, we're not seeing virologic failure. In fact, in many of these switch studies, we're seeing that people do sometimes a little bit better with switching than with staying. I think the one caveat is in the heavily treatment-experienced patient, the patient who may have drug resistance from prior therapy. There we know you have to be careful especially with simplification type switches. For example, in the SwitchMerck study where patients were randomized to stay on a lopinavir-ritonavir regimen or to switch to a raltegravir-based regimen, those who switched had more virologic breakthrough and failure. But the reason appeared to have been that they had fairly extensive treatment experience and that the switch did not take into consideration prior drug resistance that they had. So if you're switching from a high barrier regimen, such as a boosted PI regimen, to a lower barrier regimen, a regimen with NNRTIs or integrase inhibitors, you have to be fairly confident that the other drugs in that regimen are active. So those are the kind of switches I think we can get into trouble with. But in a simple switch from a first-line regimen or a switch in a patient who's never had virologic failure on any regimen, that's fairly simple to make a switch that may involve simplification, even a reduction in the genetic barrier to resistance for that drug.